My name is Liz Goldman. I'm here to discuss screening and initial management of metabolic syndrome at Citywide Focus. Our learning goals today are to discuss the risk of metabolic syndrome from antipsychotic medications and for how to screen for metabolic syndrome in Citywide Focus. Also be discussing some tools for initiating treatment and primary care referral, as well as common interactions for go-to medications. I wanted to start with the case of Mr. J. He's a 45-year-old man with schizoaffective disorder, multiple psychiatric hospitalizations, and prior suicide attempts. He has command auditory hallucinations and has been relatively stable on valproic acid and olanzapine. He's been living with his mother and attending a day program 3 days a week. His father died when he was in his 40s of a myocardial infarction. It's very well known that ischemic heart disease is the leading cause of death in patients with severe mental illness. This slide aims to highlight that patients who have severe mental illness die of very similar causes as patients without severe mental illness, except they die 10 to 20 years earlier. In the left-hand set of columns represents the United States population. The right-hand columns represents patients with severe mental illness. In black, you can see across all groups, patients die most frequently of ischemic heart disease, and second most commonly of cancer. But these graphs look very similar. Antipsychotics are well known to be associated with metabolic syndrome. While clozapine and olanzapine most commonly cause metabolic syndrome, you can see significant weight gain, frequent increases in the fasting blood glucose, and elevations in lipids across most of the antipsychotic medications. Our goal in this CRANIUM Pilot is to help identify patients with metabolic syndrome and help support the initial treatment and expediting to primary care. The intervention consists of a registry in which we identify clients without labs within 1 year in the Envision system, LabCorp, and Avatar system. And then time lab draws to treatment plans and facilitate these lab draws by preparing and delivering lab slips for the physicians. If patients have challenges getting to the lab draw or the primary care, we have a peer navigator available, as well as a primary care consultant available electronically and in person for educational sessions. Returning to Mr. J. He had a new diagnosis of hypertension with a blood pressure of 155/90. We developed an algorithm based on national guidelines and local guidelines that we then simplified to expedite and facilitate easy identification of when to refer a patient, as well as when to initiate a medication. And we selected medications that would be easy to use with few significant side effects and few interactions with medications that are frequently prescribed by patients with severe mental illness, and also require little follow-up in terms of blood draws for monitoring purposes. So for a patient with a new diagnosis of hypertension, we categorized patients' blood pressures into 3 groups. A high-risk group with patients with a systolic blood pressure of greater than 200 or diastolic blood pressure of greater than 110. For those patients who are symptomatic with chest pain, shortness of breath, or new headache, we recommend immediately sending them to the emergency room for further evaluation. Otherwise, if asymptomatic, we're recommending sending them to urgent care the same day if possible. These folks need to have expedited primary care if they are not already connected in primary care, and they need to be reconnected to primary care or seen urgently if they are connected to primary care. For patients in the middle group, we recommend that if patient's systolic blood pressure is greater than 170 or diastolic blood pressure is greater than 100, that the physician start amlodipine 5 milligrams daily. If it is greater than 140 or equal to 140 systolic, or greater than 90 or equal to 90, greater than 90, greater or equal to 90, we recommend the provider recheck the blood pressure and initiate amlodipine 5 milligrams daily if the reading is elevated over 2 visits. These patients also need a primary care referral. For patients with a systolic blood pressure of less than 140 or diastolic blood pressure less than 90, their blood pressure should be rechecked in a year. Common side effects of amlodipine are dizziness, fatigue, flushing, and palpitations. Rare, serious side effects, which include lower extremity swelling, are important to note. We recommend as a result to have caution in patients with congestive heart failure. We reviewed drug interactions between amlodipine and all psychotropic drugs on the CVHS formulary. There were no absolute contraindications. Among antipsychotic medications, amlodipine may increase the serum concentration of aripiprazole. Antidepressants, duloxetine, glucosamine, and MUO inhibitors may cause orthostatic hypotension, and this may be exacerbated in the context of amlodipine. Among mood stabilizers, carbamazepine may decrease calcium channel blocker efficacy. Mr. J also had a new diagnosis of diabetes. His hemoglobin A1C was 7.5. His liver function tests were normal. In this context, if his hemoglobin A1C was greater than or equal to 9, we recommend the provider start metformin 500 milligrams twice daily if his creatinine is less than 1.5. We also recommend starting Atorvastatin 20 milligrams at nighttime if the ASD and ALT were both less than 120. These patients should have a new expedited primary care referral if they do not otherwise have a primary care provider. The Atorvastatin does not need to be taken at night if it is easier for a patient to take it once daily in the morning with the rest of his medications. The hemoglobin A1C is between 6.8 and 8.9. We recommend the initiation of both metformin and Atorvastatin. And they should have a primary care referral. The hemoglobin A1C is less than 6.8. We recommend rechecking in 1 year. While metformin can commonly cause some nausea, bloating, and gastrointestinal upset, rarely does it cause lactic acidosis, though it is more common in chronic kidney disease or in patients with liver disease. It is very uncommon if the creatinine is normal and the patient does not have congestive heart failure or chronic kidney disease or end-stage liver disease. Metformin also has no absolute contraindications to medications that are on the CBHS formulary. Among antidepressants, metformin may increase the serum concentration of bupropion, and fluoxetine may increase the risk of hypoglycemia. Among mood stabilizers, lamotrigine, metformin may increase the serum concentration of lamotrigine. Atenolol, propranolol may alter glucose metabolism, and T4 and T3 may decrease hypoglycemic agent efficacy. Nicotine replacement may increase metformin levels and risk of lactic acidosis. Mr. J also, unfortunately, had a new diagnosis of dyslipidemia with an LDL of 220. We similarly created an algorithm for hyperglycemia and grouped it into 3 groups. For patients with an LDL of greater than or equal to 190, we recommend starting Atorvastatin 20 nightly if the AST and ALT are less than 120. Similarly, for patients with an LDL greater than 160, we recommend initiating Atorvastatin. Both of these groups require a primary care referral. For patients with an LDL of less than 160, we recommend rechecking in 1 year. When we looked for drug interactions between Atorvastatin and the CBHS formulary, we found no absolute contraindications. Atorvastatin may increase the serum concentration of naloxone, and fluvoxamine, nifazodone, fluoxetine may increase statin levels and associated have an increased risk of myopathy and rhabdomyolysis. Oxcarbazepine may increase statin efficacy, and atenolol and propranolol may decrease statin efficacy. We hope to support initiation of these early medications, and one approach is through the e-referral system to primary care. When you're submitting e-referral to primary care, it's important to include some key components in that submission, which would include the diagnosis, what the abnormalities are, and some important key laboratories. For instance, if you're submitting for a patient who has a new diagnosis of diabetes and a hemoglobin A1C of 7.5, it is important to include the creatinine of 1.4 and whether the liver function tests were normal or not. Overall, it's really important to understand that there are many key elements and areas for intervention. And if there is one thing to do, we really want to highlight that encouraging patients to stop smoking would be the most important and have the greatest impact on their life expectancy. We then want to encourage initiation of treatment for hypertension, followed by dyslipidemia, and recognize that among patients with severe diabetes, these low doses of metformin alone are unlikely to solve the overall problem, and sometimes nutritional interventions can be as strong and impactful. One of the known challenges in the system is getting people into primary care. So I wanted to discuss some strategies for expediting primary care in these patients. Obviously, a patient has an established primary care provider with a recent visit within 2 years. Then when patients have any abnormality, the key is for communication with these primary care providers. If a patient has an assigned medical home but no prior visits, and the medical home is in one of the COPC clinics, it is new patient appointment line. And we've developed a CRANIUM primary care medical home guide that includes these phone numbers and a list of all COPC clinics and consortium clinics with their addresses and phone numbers. If the patient does not have an assigned medical home, the first step is to determine what their insurance is and where they're eligible to go. And contact the insurance company and then select a medical home. And from there, to work on expediting a primary care appointment. Thank you.